if men were going around and like their penises just not work sample, like there would be such an uproar. Like they would be throwing money and there's a huge movement in women's health. I don't think it's erupted. That's why I'm excited to like join these women and then really just get the word out there. When I was pregnant, my weight was up to 320 pounds. And my doctor, she started me on that and it changed everything. Obesity is actually a chronic disease. This is not due to a lack of willpower, not a moral failing, not a lifestyle choice. We have these areas in medicine that are just a spotty gap in knowledge. And I saw that with obesity, but also with women's health. I went through personally with PCOS, with my infertility. As women, rate of miscarriage is so high, but I feel like we don't talk about it. Kind of like we live in this shame. I don't think it's something to be ashamed about because it happens so frequently. I want my career to work for me kind of thing. At the end of the day, I'm like, I want to create a life that will work for me. So this is going to be the first episode of Dear Suga. And today I have a very special guest. She is Dr. Tui Lauilefue. And not only is she a doctor, she's a very good friend of mine. And I'm very fortunate or very blessed that she's part of my life. And so without further ado, welcome our first guest, Dr. Tui. Thank you so much, Nani, for having me. I'm so excited to be here. And I'm so excited for this launch and for everything that Dear Suga stands for. And I really look forward to all the other interviews that you're going to have. But I feel very special to be one of the very first ones, Felt. So thank you. You're putting yourself out there. But I'm almost curious, if you weren't a doctor, what other career path would you have taken if you weren't a doctor? If it were up to me, I would probably be doing something musical. So when I was a kid, I really wanted to learn how to play the guitar, but my dad didn't want me to play the guitar. So he wanted me to play the piano. So I went to Angwa for piano lessons. And I don't even know if we talked about this. So my piano teacher was Mr. Paul Poesi. Shout out to Paul. So he taught me a lot of the basic lessons, but really the goal for my parents was for me to play in the church. I enjoyed somewhat, but again, if it were up to me, I'd probably do something musical with the guitar and on stage and probably singing. And then probably, so you know me from college and my taste in music, and probably be like one of those emo singers up on stage, just crying their heart out. Always your favorite piece to play. For the guitar, I love the intro to It's Glycerin. It's by Bush. So that's my favorite one for the guitar.
Since we're in terms of music, I know really well that you love karaoke. And so people don't really know that either. But since
Fun fact about music. Fun fact.
since we're talking about music, what is your go-to song?
It's a tie. It'll have to be Jewel, Foolish Games. And you've heard me sing this like 1,000 times.
Yes, I've heard it, but then our audience doesn't know what it. So you have to give a snippet of what that would sound like.
What? A snippet?
Yes.
Purple Rain, Prince. Yeah. Between those two. Ooh, and then Sinead O'Connor's rendition of Nothing Compares to You. So top 3.
But you have to at least try and, okay, we're inserting this in here. So you have to at least put a snippet of it. It's not as like,
What kind of podcast is this? I thought you said the goal is to make the guests feel comfortable.
because I know this is the way that makes you feel comfortable.
And then, oh wait, you want me to say it with okay. Purple Rain. Usually the season I rush shot is it like three wine glasses in. No, I never need alcohol. I just let's go.
Okay, so you've been recently been invited to a couple of things, and one of the most recent event that you've been attending is a pageant where you actually are one of the judges.
Yeah.
Can you talk a little bit more about what that?
Yeah. So this pageant, it was such an amazing concept. So it was Upomoni. So she reached out to me via social media. So she is actually the sister of one of my good friends, Puna. And she came to me with this. It's a women's empowerment pageant. You take contestants, and it's not so much a competition. It's more like a celebration of women, who we are as women in society, our femininity, and just the different hats that we wear, the different roles that we play in society. So it was a gathering for not just the women's empowerment pageant, but it was for Upumoni. It was a celebration of her 50th birthday too. And it was this big milestone. And then for her to come up with this concept where not just celebrating on her own, but having everyone share in the celebration with that focus on women, I thought that was such a clever and good way to celebrate us, celebrate women. And I ended up taking a lot of my family. So we got to dress up. It was a very glam event. So we got to dress up because who doesn't like a chance to dress up every now and then?
And so what did you look for when you were actually judging?
So they gave us different categories to look at. So there was a puletasi category, talent, of course, and there was, and I like this one. So it was instead of just having like your usual interview category before they went into the interview questions, they actually had the contestants share a little bit about their life story. So then we got to learn a little bit about all of them. So how they got to where they are, what their role is when it comes to like women empowerment, what they do for their community. Someone did like a PowerPoint slideshow about real estate that later transitioned into like her karateing her husband and then like Fuki slamming him on stage. It happened. Yep. And she did it twice. Yeah. No, but it was hilarious. It was hilarious. And he was a good sport. And then there was some singing. And then there was even this really cool one where she did a painting and it was live up on stage. And then at the end, she like turned it upside down and it was one of Jesus because it was a big part of her life and her religion. So it was really good to see that artistry come out.
Let's pivot a little bit. You grew up in Samoa, and ever since I've known you, you always had this aspiration to be a doctor. When did that actually happen? What actually inspired you to pursue that path?
Growing up in Samoa, I don't think I always had it in my head that I was going to be a doctor. It was one of those things. Growing up in a pretty strict household of educators, my dad, he worked for DOE, Department of Education. Before that, he was like an English teacher. And then my mom, she was a librarian. So that's where I would hang out after school. I was still the only girl. So after school, it's like, Tui, okay, let's go here. And I'd wait for my mom to get off. And what else is there to do but just to read books? So I did a lot of that because they were very big on education. And I don't know if it's like a Asian Pacific Islander thing, maybe, but it's you gotta grow up and do something like lawyer or doctor. But I was never good at public speaking, believe it or not. So I like to speak a lot, but a lot of it sometimes it just doesn't come out right. So I'm like, I don't think I could ever be a lawyer in high school, but they put me in the speech contest. Every time I would go on, I would just bomb. Like I could never, but they kept asking me to do it. But I'm like, no, if I can't do that in front of like small group of people, there's no way I'd be able to defend myself or defend anybody else in court. So I'm like, okay, that's out. But with medicine, I'm like, oh, that's right. One-on-one. And not just that, but growing up in the island, American Samoa, very small territory. We have very limited resources. For us, it's by the time like we're really sick, that's when we would go to the hospital. There wasn't a lot of emphasis on things like primary care, like preventative medicine. And that's what I saw growing up. And I saw that in my own family members. So that kind of really, drew me like, hey, I like spending time with people. I enjoy being with my family and I want to do more than I can as just one person. So that was always within my realm of possible or like potential career paths. And it wasn't until I got to college and then I learned about all these different paths that we can take to get to medicine. And that's when I decided to, hey, maybe let's try to go into it and just see what happens because I knew that you could have a strong desire to do anything, right? But it doesn't necessarily mean that you're going to get there. Sure, with a lot of determination, you definitely will get there. I thought possibility for me. So
You had a very interesting path into medical school. Looking at currently where your career is now, it seems like it was such an easy path. Would you say that's the same for you?
no way. Is definitely not easy. When I think about the path that I took as an undergrad, actually going in to declare my major, right? I go in, I'm like, hey, so I want to major in biology. I want to do pre-med. These are all the courses that I want to take. And you just need to give me your approval. I still remember how I felt I left feeling very upset, but also determined because, hey, just give me the approval. This is what I want to take. But it was met with a lot of, are you sure you want to do these classes are hard. You're doing multiple science courses, math course. You have to take all these other ones, biochemistry. I'm like, yeah, those are the pre-med courses that I have to take in order for me to get into medical school and do what I need to do. And I don't know, maybe that's what he tells all his students, but I don't think so. I feel like he just said that because I was not local. I had just moved from American Samoa. And then to have someone doubt me and he doesn't know me and I know me. So I felt very offended, first of all, but also determined. You don't think I'm going to make it? Eventually he gave me his approval. I felt like I had to prove myself, which is silly now looking back. But like people like that, like you will encounter a lot of people who will look at you a certain way, look down on you, just very patronizing. And a lot of these microaggressions, I felt like it lit that fire under your butt. I came here for a reason. This is my goal.
I don't care. You're in my way. I'm going to just do it. So I did all the classes. Was I the best student? No, which is, I was in shock. When I was in Samoa, I remember like we'd have to study and do all the things to get the grades, but it was different when I moved to Hawaii because we had lab. I felt very overwhelmed. There was like a lot of culture shock too, because it was a different place. I remember going to Hawaii and being so impressed by Walmart. And I remember going up on the elevator. I'm like, oh my gosh, like I made it. I'm here now. In some, we weren't like a very traveled family at the time. I basically just stayed there my entire life. The only time I would go somewhere is when I would go on a plane with my grandma or go see my dad's family in Upolu. That's when I would travel. But now being in a completely new place, all of a sudden you had to learn all these new things, how to network with these people. It was such a shock. So doing all the classes, not having the best grades, being okay with that. It wasn't until like my junior, senior year that I snapped out of it. I think it took me like 2 years to really like, oh my gosh, if I keep going this route, like I'm going to need to turn things around and do the work, study, pass my MCATs, and very proud of this job. But I did all the copies. I was like super proficient at the Xerox machine. Machines have since then evolved and they're a lot easier now. But this machine was like, it took some finesse. Like it was hard to get it to do what you want it to do. So I started there with the Department of Psychiatry. And then eventually I went on to become one of the research associates. And it was within that department, the Department of Psych, that I then had that mentorship. There were people who helped give me advice and because they knew I wanted to do med school. And I let everyone know. I'm like, I'm doing this because I want to get into med school. And that's one of the things. As far as your goal, you can't keep something like that to yourself. You never know who will be there to listen. And they'll be like, oh, here, I have this connection. Or hey, I know this person that can help you get there. Or you want to volunteer. There's an opening here. So I remember I was pretty vocal about that. But I always knew in the back of my head, I'm like, oh my gosh, what if I don't get into med school? I told all these people already. I'm like, oh, there's no going. It's already out there. You just put it out there. And maybe it was just like just blind hope. But I think that kind of carried me throughout that journey. Just put things out there and then it'll come back. It's like a boomerang effect. I was just thinking about, you remember you have a t-shirt. I think that was like your favorite t-shirt. Oh yeah, my black one. Yes. Says, trust me, I'm a doctor. I still remember that. And then I would see a vocal stage. Yeah. No, but then that's a great thing though. Affirmations. That is affirmation. That's true. To me, I'm like wishful thinking. I'm just going to wear this around. And then one day I'm going to wake up and oh my gosh, a white coat. Oh my gosh, a stethoscope. It's going to happen. So would you have said that you were one of those people that actually map things out? This is how I want my life. Because I feel like sometimes I'm like that where I'm just planning things out. And so were you at that same stage where you're like, okay, this is exactly how I want to be, or real million putting it out there? You know me, I'm not a planner. That's more your skill set with the detail. Like for me, it's like all I know is I know what the end goal is. And then whatever I do, it's will this help me with my, there are a lot of things that I did that probably didn't help me with my goal. But for the most part, it's okay, this is where I want to be. This is where I want to go. And then just work towards that. And when I did my exam, I am a terrible test taker. But the thing is with med school, everything is an examination, is an evaluation. So I tested very poorly. When I did my MCAT, I have such bad test anxiety. Like I would never sleep the night before. I would go in and I would find myself reading the same question over and over, like nothing would stick in my head. So I was always so nervous during exams. So what happened was I had to retake my exam and I had to sign up for Kaplan classroom courses. I'm like, I can't learn this on my own. I need help. So then finally I got like a passing score. Thank goodness. And then I was able to apply. But even when I applied, it was so hard. I felt like I didn't know enough people. But I was so fortunate because then I found out through my family at the Department of Psych about this program as the Iniho'ola post-baccalaureate program. I applied for Iniho'ola, I interviewed, and I got in. And then once, that was probably the hardest year out of all the medical school years. The year in Iniho'ola, it's like boot camp to prepare you for med school. And I met a lot of people in Iniho'ola and we're still friends now because after going through such a grueling year together, it's like, oh my gosh, these are my people. Like you get to know each other really well. And it's great because Iniho'ola is not just focused based on academics. Like they actually hired the her name is Karen, but she was like our learning advisor. And then prior to this, I've never done any kind of program where they would teach you about yourself. Like they would be like, okay, this is the kind of learner that you are, like based on this test that you did, but you do better if you're like an auditory kind of, that's why I'm like, I sit and read books. I'm like, oh, I can't do it. This is so painful. So that's why I like to listen to podcasts and like Audible. That's how I consume or ingest my books, if you will. But I feel like once you learn about yourself, then you're better able to understand why you are like attracted to certain fields and why you respond to certain things in a certain way, like why I feel so energized when I'm around other people because I was very much extrovert in that test, and why like some people, and it helped me understand other people too. Everyone is different. People have their strong suits and people have things that they can work on, which is for all of us. But it really opened my eyes to knowing about myself. This is how I like to learn. Now I know my limitations, or now I know I get to play into my strengths some more by just being around people and then learning in a group setting.
So the fact that you were in Amy telling me about how like you didn't have the right MCAT scores, you just did feel like you were well prepared, but you still made it to medical school. Now, years later, you actually became part of the admission board, right? And so tell me how did that change for you? What were you then starting to look for in candidates?
So the tables did turn eventually. After medical school, I stayed in Hawaii, University of Hawaii. I went through intern year there. I did my residency. And then so my first doctoring job was with Queen's Medical Center, right? But I was also very involved with working with the medical students, working with the residents, but also got to be part of the admissions committee. Thought it was a great experience by the time a student would even consider applying, because they would have like minimum, okay, you need the score, you need to do this, do that. I'm like, all these kids are bright. Like everyone has the academics part down. That's great. But what I was really looking for was just the in-person part. Because you could be like the smartest person, but if you don't know how to talk to your patient, if you don't have communication skills, they say a lot. Like, what sense is it to be like the smartest person with the highest score if you can't even convey the news or explain a diagnosis? Sit down with your patient and just meet them where they are and really be there for them. I enjoyed reading their personal statement, looking to make sure, okay, so they've done a lot of different things, but that's what I like to see. If I see an application and I'm like, oh, so they've actually worked and they've done this and they've done, and not just like volunteer. I like it when I see that they've actually worked a job. And maybe I'm biased this way. If you're just volunteering and doing all these things, I'm looking for the struggle. Where is the struggle? What part of this application tells me that you have grit, if you will, like you are resilient? It's like shit hits the fan. What are you going to do? Are you going to be able to recover from this? And even in med school, like it's so hard when somebody, for example, fails something and then they don't understand how to recover from something like that. That's why I like to see that in applications. It's okay, so this person has been through some things, they've lived life. And that's what I like to see. I want to make sure they are a genuine human being, that they actually care to be there. They care about their patients, because these are the people who are going to be taking care of us, our families. And that's the kind of doctor that I would like to have, or that I had. I was lucky enough that the doctors that I had there were like that, and they were in private practice. So they were very available. It was important because I feel like we need more of those kinds of doctors. I'm going to go off on a tangent. With all that's happening in healthcare right now, I feel like some doctors are stuck in that setting, or they feel like you don't have that autonomy. And then what happens a lot of the time is somebody else is responsible for your schedule. Somebody else is telling you like how many minutes you can spend with this patient. Like someone else is making all those decisions. And to me, that's like a recipe for burnout, right? Especially if you are in that kind of employed setting.
There's people who actually just enjoy their job being at the trip in the hospital. It seemed like that was the path you were willing to take. There's been a shift. So what made you decide just have to make a change now?
You bring up a good point. So it wasn't as if I was ever like unhappy in the employed model. I started at Queen Emma Clinic. I love Queen Emma Clinic. The people who I got to work with were the people that also taught me as a medical student. So it felt like home as far as like the workplace. I'm like, oh, this is what I love to do. Because in residency, we would do inpatient medicine. Every week we would have continuity clinics. And I knew that the clinic was for me because that was the one thing that I would look forward to like all week. I'm like, yes, I have my continuity clinic this afternoon. I'm going to go and see Dr. Igno and see my patients. And it was just the narrative. I love to chat. So whenever I see my patients in the clinic, I know that I can see the same people. So I get to learn about them and follow them along this path. Because we're in the hospital and somebody is hospitalized, it's like after I leave or after that rotation, I'll never see them again. They're already better, they're at home. I don't get to see that continuity, but clinic allowed me to do that. So that's why I always liked it, because of that reason. It wasn't until we left Hawaii, right? So we moved here to Washington. My parents, everybody came with me. My husband does have a lot of family in Washington, which is mainly why we decided to settle down in this area. And then when I moved here, it was an employed job. It was more corporate medicine. There was no teaching. And I did that for 3 years because it was a 3-year contract. So for every year that I was employed, there was always like a new organization. There's like buyout, right? And it was different because it wasn't necessarily an academic setting. I felt the focus shifted and it wasn't really even about the patients. Like we felt a lot of pressure to meet our numbers. They looked at things like you have to meet these metrics and do all these things. And then it's check, check, check. I'm like, yeah, but just because we do that, does that even really improve patient care? You ask me, that's just my opinion. I don't think it really did. I felt like we were just rushing through all the visits. I didn't get to doctor the way that I want to doctor or that I feel like the patient deserves to be doctored, right? Just giving that available time to them. And it wasn't until that 3rd year, my last year, that I got pregnant with Zoe that I decided maybe this is not really for me. And even before that, before I was pregnant with Zoe, so my husband and I, we've been struggling. I have PCOS, right? And I'm pre-diabetic. I have a lot of insulin resistance. And I used to be much heavier than this. So we were struggling for a long time with infertility. We had to see an infertility specialist. Shout out to Dr. Maruzzi, who really helped us get to a point where I was then able to be pregnant. During that infertility journey, I don't know, should I talk? So during that year, while we were trying to get pregnant, and it was the first time I was ever pregnant. So we were so excited. And then I was in the middle of work in the middle of the day. And then I'm like, oh my gosh, something doesn't feel right. I'm bleeding. And then I went to the restroom. I'm like, oh my gosh, this is not like normal bleeding. Like it was just like coming. So then in my head, I'm like, oh my gosh, this can't be happening. I'm like, oh, but it is happening. And I'm like, I'm not even going to call my OBGYN because like they can't do anything to stop it. It was way too early. It was like just first trimester. And then what did I do? I'm like, you know what? I'm just going to make the bleeding stop as much as I can. And then I'm just going to go back to work and I'm going to finish seeing my patients and then I remember I called my OBGYN and then and it's happening, then just come and see me now. I'm like, wait, I had to see all my patients and then I'll come see you. And that's what I did. So then I stayed, I saw all the people on my schedule and then I just went and saw him. And then when I got there, yeah, you're having a miscarriage and there's nothing we can do to stop it because it's so early. So then I remember going home that day and I was just so devastated. But I feel like it's like one of those things as women, because the rate of miscarriage is so high, but I feel like we don't talk about it. Like we live in this shame. And I don't even think it's something to really be ashamed about because it happens so frequently. But I'm happy to share my story to let other women know it's, hey, this is something, it's a very real possibility. And it happens more often than we think, or it happens more often than we even talk about. So that was the real turning point. I'm like, you know what? Life is too short. I'm not going to keep working because at the end of the day, like my goal is to spend as much time with my family as possible. If I have such long days and then I get home, I'm like, I'm tired. I don't want to do anything. I want my career to work for me kind of thing. I don't want to live life so I could work. I care about my patients, but it's at the end of the day, I'm like, I want to create a life that will work for me in order for me to do the things that I want or in order for me to spend the time with the people that I want to spend time with. And then to me, that's like my family and and you're my family too. See? So that's really why I did it. So after that happened, it wasn't even a year after that we were so fortunate we got pregnant again. And then that's solely you having to make this transition into more being an entrepreneur. And the only reason why I was asking that is because I think there's so many great doctors out there that actually enjoy in a corporate setting, and there's nothing wrong there. And I also think there's nothing wrong about having to own your own business. It all depends on how everyone has a story to tell. Yeah. And this is yours. You had to look into a business and you have no business degree. Nope. And so what was the next phase? So even when I was employed, I was part of these Facebook. They have all these different doctor groups, but specifically it was the DPC docs group. Direct primary care is such a breath of fresh air when I heard about it. And the way that I understood it then was instead of working for insurance companies, your doctor works directly for you, the patient. So you contract with your patients. They would pay like this monthly subscription fee. In exchange, patients will get really good access to you, meaning they could text the doctor, email. It's like having a doctor in your back pocket. And then the direct primary care model like we keep the patient panel very small, right? So I think average size would be like 300, 400 patients, and then that would be it. Because the smaller your patient volume, the more time you're able to spend with them and the more available you can be for those patients. When I was employed, we had, I think on average, like every doctor, nurse practitioner, or whoever the provider there was, it was 1,500 to 2,000 patients, everybody under your care. And it's almost impossible to remember every single person and then knowing, okay, this person, it was like a new person every time you would see them. So it just felt like assembly line medicine, if you will. It's just people coming, going, coming, going. You only have a small amount of time to address every single issue. But the direct care model, so when I got into that group, I'm like, oh my gosh, so if I have my own practice, then I don't need to go the insurance model. I could finally practice medicine the way that I feel like I've always envisioned, not just for myself, but for my family. Imagine calling your doctor and instead of going through call center, right? It's, oh my gosh, I can never, then you're on hold, then, oh, transfer. And then you don't talk to your doctor, but you talk to a different person, like whether it's a nurse or a triage person, and then you leave a message. It's like almost impossible to reach your doctor directly. But this model allowed for something like that. So I was very excited to read about it, learn about it. But then the big question was, how do you start a business? What do you have to do? And around the same time, I discovered Dr. Una. Dr. Una is amazing, but she was the one that really inspired me or made me believe that you can do this. I could hear her in my ear. You went to medical school. Medical school is hard. Starting a business is hard. Like, if you could do that, you could start a business. And at the time, I'm like, I feel like a fraud. I had a lot of imposter syndrome. I don't know anything about a business. Where do I start? Where do I go? Oh, I fall back on that Facebook group with all the other doctors doing it already. So for me, seeing that and then reading about everything that they were doing, I was like, wow, people are actually out there living this, that this is their reality. This is their life now. This is possible. There's some really good books too. There are more now, but at the time they had How to Start Your DPC Practice. And then what I did was I made my checklist. How do I start a business? Google. It's like, how do I start an LLC? After I got my LLC, I have my business account ready. Where am I going to put patients in? Like, where am I going to be able to see my patients? So it's a small community. So I heard from a doctor that another doctor had an open office space for lease. So I called him, got something set up, and it went very quickly. It went very quick. I was very fortunate that it happened that way. It's important to have those connections, right? And if I didn't let people know that I was looking, that doctor would never tell me, oh, so-and-so has an open space. You should talk to him. And then that goes back to just putting things out there. Like, whatever you're trying to do, I feel like it's just important to just share it with people because you never know what's going to come back to you.
It seems like you were always tweaking things at the same time.
Oh, yes.
Work in progress always. Yes. That's something even now that we're much more wiser in age. It's not necessarily perfection, but progress.
Yeah, I love that. I love that. That's like my mantra, right? It's like progress over perfection. It's so easy to get stuck in that rut, right? You have analysis paralysis. I want to do this. This is my goal, but I want to research all the options. I want to do this research, do my pros and cons, do the thing, but it's just do it. Yeah. And then just know that just because you decide to do something, it doesn't mean you can change your mind. It doesn't mean you can improve on it. So if I have that mindset, it makes it easier for me to just decide on something, right? Because I'm like, okay, I'm just going to go with this. And if it doesn't work out, then we'll do the other thing. But if I don't start somewhere, you're never going to move. I do remember when you were in medical school, because I remember asking you before, I was like, are you going to do your fellowship and all that? I was like, oh, I'm done with medical school. You learned exactly right. Oh yeah. I was like, I'm done. I don't want to do anything extra. And I know even like the chief year thing, I was like, I don't want to do that year. I'm just going to start. But now I still have my internal medicine board certification. The thing that we're talking about is why I decided to get my board certification for obesity medicine. Most of my adult life, I had obesity. Going through medical school and residency and having counsel patients, I felt like that was very hard for me, especially when it came to addressing body weight and telling people how to eat, telling people how to move or exercise. I always felt like such a hypocrite. I'm like, and I'm like, who am I to tell these people what to do if I can't even get my stuff together? I felt like the approach that we were taught in medical school was not enough. When I started learning about like how obesity is actually a chronic disease. This is not due to a lack of willpower. This is not like a moral failing. This is not a lifestyle choice. The way that we see it as a society and for most people, which is sad, and I think it really has to change, is that people have obesity because they choose that lifestyle. I'm like, no, that's not the case at all. It is a disease. There's so many things that brought up enough. I think it's just the way that we were training. Like in med school and residency, we were trained to just tell patients to eat less, eat better, move more. And then we wouldn't offer anything other than that. Thinking back, I'm like, oh my gosh, I feel so ashamed. That's all I told patients. And then I learned much later, no, like we have very effective medication options that have been around for a long time that we just have not offered as an option to patients with obesity, right? Because if you think diabetes is a chronic disease, hypertension is a chronic disease, and you see a patient in your office and their diabetes is so out of control, there's no way that you're going to let that person leave without coming up with some kind of treatment plan. But then we see patients who have a high BMI, they meet the criteria of class 1, class 2, like class 3 obesity, and it's so severe. And then some of those patients, like it doesn't even get brought up, but we don't treat obesity the way that we treat other diseases. I think there's still a lot of stigma. People have their own like their biases, something that we definitely need to work on as a whole, like in society. But now that I know better, just through the studies, I'm really trying to apply that like to my patients and letting them know that, hey, you have this, it's a disease, but guess what? We have treatment options. This is treatable. And with just some of the latest medications that are now available, especially like the GLP-1 shots, they have been life-changing for so many patients. And I've seen that change, not just in them, but actually in myself, because when I was pregnant, my weight was up to 320 pounds. And my doctor at the time, she started me on that, and it changed everything. And it really made me rethink our whole approach to obesity and how we still have so much work to do to get people to understand that this is a disease. We can treat it. Nothing wrong with seeking treatment. I know that patients want treatment, and then they have people shaming them or telling them, oh, you're cheating, you're doing that shot. I'm like, what are you talking about? Like, I have a disease and I'm getting treatment for my disease. Are you guys going around telling kidney patients or dialysis patients, hey, you're cheating? How dare you use the dialysis machine? Why don't you depend on your own kidneys? We're not shaming people for that. We're just shaming people for wanting to get better, live healthier lives so they can be there for their family, be there for their loved ones. So there's a lot of a double standard when it comes to the treatment of different chronic disease.
You're very allopathic. I really talk about this a lot. And I'm more like, I like to just try and make sure, okay, I'm going to try to eat right, eat clean. And for quite some time, I'm just hesitant to do it. But you give me a different perspective. Just what you just said now was, am I cheating if I have to go to do dialysis? But I also think we're not here to encourage anyone to be like, oh, take on, but I think it's just making more informed decisions.
Yeah, you have options that you have. And do I think everyone needs to take these medications? No. At the end of the day, like if you have all the information, you have all your options and you just decide whatever is best for you. Staying informed, and it's okay to say no. Like I have people in my weight loss program that prefer not to do any medications, and that's totally fine. And they want to work on more lifestyle interventions, diet, exercise, mindset, and then that's fine too. I also want to make sure that patients are setting very realistic goals and then making sure that their expectations are also very realistic, because there are certain patients where if your BMI is high enough, diet and exercise will not get you to where you need to be. And then so I like to think about it like in this pyramid where you have lifestyle interventions down here. And then as you go up, the risk goes up, the complexity goes up, and the cost goes up. So probably the most effective would be something like bariatric surgery. And you can expect to lose like anywhere from 30 to 35 up to 40% of your body weight from surgery. But some of these newer medications, again, the expected weight loss from them are pretty up there, like 23% average, like for Mounjaro or Zepbound, for example. So depending on where you start, you don't necessarily just have to start at the bottom. If somebody comes in, they're already so sick, the risk is so high, it's fine to start with the surgery as an option. And as long as patients know that and they can decide for themselves, and there's no need to shame anybody. If your goal is to be healthy, then these are the options you get to pick.
So we're going on the other extreme, which is not necessarily weight loss, but there's also people, like you've said, skinny fat, and that's usually more dangerous. And someone could actually be listening in and be like, I'm not what the standard is in terms of the BMI. I'm okay. So I don't feel like there's a need for me to actually have that kind of service. So you've talked about in terms of skinny fat,
right? So if you have like your annual physical, the BMI, there's such a limitation, right? Because it's basically your height and your weight, and then you get this number. But the problem with that number is you don't know what the composition is, right? So is that weight, is that mostly muscle? Is that mostly fat? What is the breakdown? Because you could have somebody like Dwayne The Rock Johnson, and he probably meets like the higher BMI, but if you look at him, it's because his weight is high because he has so much muscle. So you would not look at him and say that person has obesity. But based on the BMI criteria, like you probably will meet that. So when somebody says, oh, I don't think I meet that, my BMI is always normal, depending on if they have risk factors like within their family, because there are people who tend to carry more like visceral fat. And then that's the fat that is not visible to the naked eye. It's like the fat that's around the internal organs that you can't pinch. It's just deep in there. The higher amount of that kind of fat you have, the higher your cardiovascular risk is, right? So you're more at risk for things like heart attack, strokes, diabetes, but you won't be able to tell unless you do something that will be able to measure those things correctly. So something that we have in the office is we have our body composition scale, right? So we do like a bioimpedance analysis, and that is able to tell us like, okay, how much muscle do you have in each arm, each leg, in your torso? How much fat do you have? And not just how much fat mass, but how much like visceral fat. So that's why I really like those measurements, because they're a lot more accurate and they give you a better breakdown. It's good to go and get checked, right? So you go and you do your wellness exam or whatever it is, you're checked with your doctor. They do like your basic labs. That'll give you like a good indication. And then adding on that body composition, because visceral fat cannot be measured by like blood tests. It's more you have to go in and get those measurements through imaging. It really depends on like you as the patient, but also the way that your doctor approaches things or how often they would want things checked. Because not everybody will necessarily follow the guideline.
You also decided after obesity medicine that you were going to also pursue getting a specialty in hormonal imbalance.
Yes. Yeah. We have these areas in medicine that are just very spotty, meaning there's this gap in knowledge. And I definitely saw that with obesity, but I also saw that with women's health, perimenopause, menopause treatment. Like even through my training, I don't think there was probably like a very small percentage of that kind of training in our school. But now I'm hearing from other colleagues who actually went into, who did OBGYN care. Of all the residencies, you would think, okay, that'll be the one that would get all the knowledge and the training on how to treat women in perimenopause and menopause. Even then, just listening to their stories, we got very little training in that. So only when I went through personally with PCOS, with my infertility, and then seeing that in my patients, and I'm an internal medicine doc. So a lot of my patients, like my average patient age is around like 65. So like most of my patients who are female, they're in menopause already. But I think there's a huge movement right now in women's health. I don't think it's erupted like all the way yet, but I think we're getting there. And that's why I'm excited that I'm like, okay, I'm already there. So now I have to join these women and then really just get the word out there. It's like half of our population. And if men were going around and like their penises just not working, for example, like there would be such an uproar. Like they would be throwing money and funding all these research projects, but it's, oh, it's women. Like things aren't working down there or whatever. Because we don't, like, if you think about men, it's Viagra. Everybody knows about that. It's, is there anything for women that's the same? And actually there is, but people don't talk about it. The average age of menopause in women in the US is around 52.4 years old. And I feel so ashamed thinking back and how we used to just villainize hormone therapy, right? Because the time that I was training would be like, oh, estrogen is terrible. It's going to give you a heart attack, a stroke, DVT, breast cancer. But it was the study that came out around that same time. It's like from the Women's Health Initiative. But now looking back, we see that it was such a flawed interpretation of the study, right? So things that we thought we knew, the real information wasn't conveyed in a way that would be really helpful to women. So it was almost overnight when that study came out. It was all over the news. It was almost like the next day, like all the women, they were told, okay, you need to stop. It happened to my mom too. Like she was on Premarin for a while. She had a hysterectomy early and then her doctor just took her off just like that. And I think she was just in her 50s. But now we know there is a window from when you have menopause. And then if you take hormone therapy within that 10-year window afterward, there are so many benefits. It's actually protected against heart disease. It helps your bones. It helps prevent against osteoporosis. So I felt really bad. That's what happened to a lot of women. It's still happening now. There's still a lot of doctors who are like, no, this is terrible. Like even vaginal estrogen, which we know any woman could have, like vaginal estrogen, there's no increased risk of strokes, heart attacks, cancer, blood clots, any of that. Something that we have to continue educating people on.
So I'm just stuck in my head. I'm sure people out there are wondering, when I hear vaginal estrogen, it just sounds very taboo. Are we just talking about just down there, or what are we?
Oh,
They're different. Oh, when you say that, I don't know what people are thinking right now.
you're different kinds of forms of estrogen. So vaginal estrogen mainly. So we call it like genital urinary syndrome of menopause. So when you hit menopause, I hear this from my patients. I'm getting more UTIs, dryness down there, like sex is painful. And a lot of that is because in menopause, your estrogen levels drop, progesterone, testosterone, and all of those things, right? So even replenishing by using vaginal estrogen creams. So you also have tablets. You also have estrogen in the form of rings, in the form of patches, which is quite, it's more the popular one. But the systemic estrogen, when you think about menopause, we always think hot flashes, this, but there's so many other symptoms that happen in menopause, like depression, anxiety. All of a sudden you have ADHD, ear ringing. You have like, all of a sudden you have dry skin or weird rashes. You have numbness and tingling, aches and pains out of nowhere. And I think this is interesting. A lot of women going through menopause, like they get misdiagnosed a lot. You're going through menopause, your mood changes. It's, oh, you now have depression and anxiety. Take some SSRIs. And then they're like, oh, okay, so SSRIs. And then that causes more issues. When all along, if we would have figured out that it's actually menopause causing a lot of these things, and that could have been treated a lot differently. You should still do your due diligence because they still could have depression and anxiety on top of that. But I feel like that's one thing that's missed a lot. When we think menopause, we think there's a stage there that just up, that just hits, but we don't really talk about perimenopause. Oh yeah, one thing I learned is okay, I'm in perimenopause phase. Yes, so look at us. Yes, kind of explain what does that look like. So perimenopause, you start noticing just like different, it presents differently for different women, like all those symptoms that we talked about. Perimenopause, it's not something that happens overnight. So on average, like you can be in perimenopause starting in your 30s all the way to your 50s. So can you imagine? It's like a huge chunk of your life. It's like 30s and then 40s and then early 50s, and then you go into menopause. What happens is your hormone levels are just going through these huge, it's like roller coaster fluctuation, right? It's like you check one day, it's like your estrogen level is like sky high. And then 10 days later, you check your estrogen level is all the way down here. So that's the moody part. Oh yeah. Like things are just, there's such a huge shift, a huge swing. I remember I was sharing, there's a person who posted a video on social media. I was like, look at this. Don't blame me. It's the hormones. This is why I'm the way I am. Okay. So I just want you to know it's not, I'm not making this up. But yeah, but it's crazy if you think about it, because we're going through this big change, and we're living it on our own. If you're not talking to your friends or your doctor or whoever about it, you're just going through this alone, which sucks. And you're like, oh, maybe this is the way I am now. I'm getting older. I'm just moody. Once you do find out, telling your friends. So I'm certified by the Menopause Society. If you go on their website, you're able to type in your zip code, and then you can find certified menopause practitioners in your area. And I know a lot of these women who are doing big things to get the word out there, social media, like they're putting the information out there. People are sharing. I think once you know about it, just tell other women about it, or not just women, somebody's husband will hear about it and then share it with their wife, and just letting them know about, hey, if you're going through this, you don't have to wait until menopause to start treatment. Like you can start treatment even in perimenopause, but it deserves sit down assessment, and then finding an expert who actually knows what to look for, what to test for, looking at your levels, and then coming up with the best plan for you, because everyone is different. So you have to personalize that to the individual patient. So here's the other question in terms of estrogen, because this is something new that I've learned about. And I think with our age, and I do skincare and the anti-aging, and so tell us a little bit more of how that's supposed to be anti-aging. So you can actually put estrogen on your face. If you think about what estrogen does, for example, if you have a woman with vaginal dryness and they're getting UTIs, and then you introduce estrogen, estrogen will restore the pH, like it recruits blood flow, it helps with vascularity. And it makes sense when you think about it, putting it outside of that area, like on your skin. So it's supposed to reduce fine lines, it'll bump things up again. It helps with like collagen restoration, and it's anti-aging in that sense. I think it also helps with hyperpigmentation, but don't quote me on that. I'm not a dermatologist, but there's some dermatologists talking about it. That's great to know. So let's talk about what's your current routine. What is something that you can't live without in terms of your skincare routine at the moment? Two things, right? Sunscreen in the morning, sunscreen. If it's anything that you had to pick, if it's one thing you have to pick, sunscreen for sure. And then retinol. You can get that over the counter. You can get like a prescription strength one too. So like tretinoin, but that one for nighttime. So I feel like those two ones are my go-tos or must-haves for skincare. I'll speak for myself. Like I'll have very minimal skin. Oh yeah, same. And then now it's just, am I being very vain that I have so many things in terms of my skincare? Especially where we grew up in terms of Polynesia, we're all about being natural. How do you perceive it? Were you also that same way? Have you always had a routine? We've been around each other long enough to know that I'm like, oh, pasimoli. Okay. I don't even think I did anything outside of the shower, really. So I think it was just learning about the benefits of this. And of course, as we get older, and even if it's vanity, how you feel about yourself. And like for me, for sunscreen, and I never had the best skin. I always felt like my skin is like ashy and grayish. And now that I'm like, wait, but if I use these products, it'll make me look more vibrant and more just like a healthier appearance. I think there's nothing wrong with that. Nothing wrong with investing in yourself. And it's like how I see our health in general, right? Because you could be a certain weight and eat like junk. You just eat junk food all the time. It's people aren't watching what you eat, but you know that your body will either get healthier or unhealthier depending on what you put into your bodies. The same vein when it comes to skincare, because if we're not taking care of ourselves, taking care of our body, I feel like for me, that'll just make me feel like meh. But also because I know I can't do makeup, like I am not great at applying makeup. I'm like, But skincare, I could focus on skincare because even without makeup, like your skin will still be able to look just vibrant. And I like the glowy skincare products too, because that just makes you look more youthful. And I think there's something wrong with that. I think giving yourself 5 to 10 minutes just to for yourself is healthy. And oh yeah, self care. And if it makes you feel good, and you're right, it could be like a like part of your relaxation ritual, right? And then going into self care, you can do it for yourself. People go and do facials, and some people do regular massages. It all goes back to that.
We're going to wrap it up. And so I just wanted to thank you for the time that you're taking to actually be on Dear Suga. The message I've been hearing is great to plan, but you just got to go with it and pivot. But you always stay true to your goal. That's something I see. But besides that, what other wisdom would you share with a Dear Suga?
And I think we did touch on this, but I feel like it's so important to get to know people, right? Depending on what your goal is, you want to seek out people who are already doing the things that you want to do. Seek mentorship from them, get to know them, be in their network, be in their circle. And it's like that saying, right? So you are the average of the 5 people that you spend the most time with. So if you find yourself around certain people that you feel like are not necessarily in line with your goals, or it's just, like eventually you'll turn into those people. Finding like minded individuals, people that are doing the things that you're doing. And even if you're aspiring together to do something, I feel like that really does help motivate you. That way you stay on track with whatever goal you have. So networking, mentorship, and putting yourself out there. But again, that requires you actually letting people know this is my goal, this is what I want to do, and then just owning that and just digging in, right? So lean in. It's so easy to say you want to do something, but if you're like half ass about it, it's like we're not here to just dilly dally. Right. So if you decide to do something, just go all in and then just do your best with whatever resources you have and then just do it. And then just know that it's not, you can always change your situation. Just because you start something, you can always pivot. So the first decision, just do it, network, and then manifest it.